Today's episode was brought to you by Prexion. Prexion is a proud educational sponsor and supporter of Dentist in the Know and has been for a while, and we're just honored to have them aboard.
As always, all of our educational partners are products that you can trust because we use them, we vetted them, we know them. Prexion is one of those companies. They have a full line of CBCT scanners, but way beyond that, way beyond the best images in the industry, way beyond the best customer service in the industry. They're just a bunch of good folks putting a great product out there. And if you've heard any of our lectures, you'll know that this is just critical equipment that every dental practice should be incorporating. So we're so proud to have Prexion with us.
Thank you, Prexion.
Hello, my Dinks friends in the Dinks world. It is Wednesday. That means it's Hump Day, one of my favorite days of the week. Not just because of the people I get to hang out with, but because of the message that we get to bring to all of you. This is just a great day of the week. So we are Dentist in the Know. We are your backstage pass for current trends, politics, and education in the dental world. We are live and we are over a cocktail. And I might add that yesterday I celebrated a lovely birthday with my parents and my wife. Had a lovely dinner, and they brought me this bottle of Belglas Pinot Noir, Russian River Valley Pinot Noir. Yeah. Really nice bottle, fairly reasonably priced. Great drinking bottle, and that's what I'm going to be enjoying with you tonight. So JB is my friend. She is my colleague. And she is the person who does the news better than either Chad and I ever could.
Thank you. Thank you for the final recognition I was looking for.
You absolutely needed it. So anyway, Dr. Chad Duplantis cannot be with us tonight. A little bit under the weather, and we all wish him and his son Austin our very best. They are both feeling very under the weather. So please think of them, and we hope that they're feeling better, and I'm sure they'll be back with us next week. But Dr. Jennifer Bell is with me as always, and we have a terrific guest tonight who is an oral and maxillofacial radiologist and a really personable guy. I got to talk with him for a few minutes. But as you know, we are all educators, we are all dentists, and we are all business owners. Our job is to bring all of you in the know. So you see what I did there with the in the know thing? I've only done it for the past 100 and however many. How many is it now?
We're almost 3 years. Yeah.
Yeah.
Like so many.
It's a lot. It's a lot. I can't even count that high. So a little bit of good news tonight.
Ooh, share.
Do you know tonight's episode? We have an incredible educational partner that is sponsoring today's show. I'm really excited about this because our vow to all of you was that we would never take on sponsorship if it wasn't products that we were using, that we have vetted, that we know the people behind the scenes, and that we can stand on a podium or stand in front of you and be willing to say, this is good. And that's what we are. We want to be your honest and trusted group for social media. And so when this company, Prexion, who makes incredible CBCT technology, our guest tonight is a witness to this. He's an oral and maxillofacial radiologist, and he has seen the images, but he also knows how many of his clients that refer to him use Prexion technology. And I have 3 of these units in my different offices. I started out just as a customer, like everyone else, and their customer support is second to none. Their product is second to none as far as quality of image, and they have become an educational partner with us. And so we are so proud to have Prexion as an educational partner, and they are a presenting sponsor for this broadcast tonight. So I thought I'd throw that out there. And that was kind of long-winded, but I wanted to share
No,
that
I
news
love
with you,
it.
JB. Yeah.
I love that you brought it up because number one, we're very transparent in who we work with and the companies we partner with. But two, there are so many questions from most providers around CBCT technology and the liability piece that comes along with what am I capturing and what am I liable for? How do I interpret and understand? What should I expect back from a read if I get it back from an oral maxillofacial radiologist? So I think this is going to be a really good conversation. I think it's going to hopefully answer a lot of the questions that I know I personally have in this world. And, maybe encourage more of our providers to bring that technology into their practice to solve a lot of the problems that they're currently experiencing in diagnostics and understanding clinical conditions. So I think it's really fun. I'm excited.
Yeah, I am too. It's it's such a practice builder. I know people are afraid of investments that they have to make in
Sure.
technology, but it's such a practice builder when you bring the right technology on and you implement it the way that it should be implemented. And
Yeah.
for me, when everyone asks that question, what's the first important piece of what we would call advanced technology that you would put into your office? For me, the answer is always CBCT. I've
Yeah.
had this. It's getting close to 15 years we've had this technology in our practice now. And I tell the story every time. Everyone's bored of hearing it, but it was a $200,000 investment for me, as a small practice. And I don't regret that decision ever.
No.
It immediately translated to our bottom line as far as not just what we could charge out for the scans themselves diagnostically, but in the treatment that we were able to provide afterwards because people could see what we were talking about. So it was a practice builder for me, and I hope everyone else sees it as that as
For
well.
sure. Well,
Yeah.
this isn't a commercial because we actually didn't plan any of this, but
No,
um, it's completely organic. But you bring up CBCT and actually not having these relationships prior to starting Dinks with you all and all that. That was the first big investment we made in our practice as well, because it's one of the few pieces of technology that you can bring in and actually bill for it. I love my intraoral scanners and I use them every day, but there's no direct correlation to the ROI. Like I don't make a transactional fee for each scan I take. Maybe
right.
it makes my life more enjoyable. Maybe I can treatment plan better. Maybe I can communicate better. Maybe I can turn treatment around in a more expedient manner. But a radiograph is an actual billable procedure. The thing that I've loved the most, though, that I didn't appreciate when I purchased my first one was I was able to solve problems for patients just by good diagnostic imaging that they had multiple PAs taken of the same tooth and it could not be seen. They had enough
Amen.
dense, thick buccal bone. And you take that PA or you take a PA over and over, and the buccal bone is thick enough you really can't appreciate, or the sinus membrane is sitting in such a way you can't see. And then you take the CBCT and it's like a lightning rod, basically pointing at the issue
Right.
that you can go to the patient and say, I can solve this problem for you. And I know exactly what we need to do. What a hero moment. And we don't get
Yeah.
many of those. Like
No.
we're plenty moments of zero, honestly. Like I hurt you too much. I took your money. All the things that people associate with dentistry. It's very rare that we actually get to walk in and be a little bit of a hero and solve a problem that maybe fellow colleagues had not been able to just visualize. It just simply was a function of visualization. And
That's it.
it's been huge for us and a confidence and practice builder, honestly.
Yeah. And when do you ever get to be the hero diagnostically? Like that?
Very rarely.
Right. That's a rarity because otherwise you're just doing the same thing every other dentist did.
Right.
And they're like, oh, that's just another opinion. But when you bring in technology that they can actually see the problem as well and it's explained that way, it's like, oh my gosh, if someone had just used this technology
I know.
before, I would not have gone this long without solving the problem. So,
Correct.
all right, we've rambled on long enough because you have some news, I am
Always.
sure, and
Always.
I'm gonna be a spoiler and say we have Dr. Barett Andreasen, an incredible oral and maxillofacial radiologist, who is going to be with us and sharing a lot of what goes on from his end of diagnosing those CBCT scans that we take. So,
I'm
JB,
so
why don't you?
excited to
Yeah.
dive into that.
Yeah, I love it too. All right, go ahead, give us the news.
All right, my friend. Well, first off, I get criticized a lot on this program that we run, that I only bring the really sad stuff, the terrible dentist practicing in the hotel room and all the things. And I do have a little bit of both for tonight. So we're going to start low. We're going to end high. Things are going to work out okay for everybody. First off, I do have to tell you that there was a settlement that was reached this week, $3.5 million to a family for a pediatric case where the child experienced a low oxygen event during a sedation appointment. And then the mom had to take the child to the ER following the appointment for some cognitive issues that she was observing. And then they were able to diagnostically attribute it to other behavioral issues that came from that. But just so that, as we all clinicians are aware, the jury did side with the plaintiff on this particular case at the tune of $3.5 million. So just if you're reviewing your malpractice coverage for your hopefully not inevitable occurrence of needing to sit before a jury, make sure that you're paying attention to where the barometers are on these cases that are coming out. And that's where the jury settled for that particular one. Now, on the happy side of things, there's a dentist out of Arizona, John Badalato.
Cocktail stone.
Yeah, Badalato. He is founder of Studio B Smiles in Phoenix and Scottsdale, and the team dentist of the Phoenix Suns. Partnered with Devin Booker, a professional basketball athlete for the Phoenix Suns, for a very lofty contribution of $500,000 to the Special Olympics of Arizona to ensure that their athletes are receiving active dental care if they're part of the program. How cool is that?
Right.
How cool is that?
Love that.
So we dentists are out there doing we're doing good work. That's really an awesome partnership. The ADA has pushed out a grassroots effort. If you're not a member, but you want to still participate, you certainly can. The Oral Health or the Dental Health Act actually is up for expiration at the end of this year. Now, the Dental Health Act helps fund a lot of state and local programs. Its primary intent is to keep kids out of the ED, specifically for dental related conditions. So opening up opportunities for access to care in the dental health community. That is set to expire, and there's no clarity on whether or not that's going to get renewed. So there's this big push right now to contact your congressmen and senators to let them know that you would love for them to continue to support the Dental Health Act and to ensure its future funding. If approved, it will continue funding for 2028. Otherwise, it is set to expire at the end of 23. Now, let's talk about this one because you and I could probably get in the weeds a little bit on this particular topic, and this is where we're going to close it for tonight. So a study came out this week about the difference between fluoride toothpaste and hydroxyapatite toothpaste. Okay. And actually, mainstream media outlets like US News and several other more consumer-based media outlets have picked up on this story. Now, fluoride's been getting kind of a bad rap recently because there's a lot of exploration right now of pulling fluoride out of municipal water supplies. The FDA is opening back up fluoride to relook at toxicity issues and how they're going to manage that in the community populations. So fluoride is kind of getting a little bit more awareness, I guess, or spotlight, we'll say. So here comes this new study with hydroxyapatite coming in as the knight on a white horse to say maybe hydroxyapatite is the new fluoride. The study was super interesting because they took a subset population of individuals. They had half of them brush their normal routine with fluoride toothpaste and half of them brush with hydroxyapatite toothpaste. They both came out with the same protective rate of cavities or caries. So the question then becomes, okay, well, I mean, you and I as scientists, dentists, whatever, would dive in that a little bit more and say, what was the over risk population? Like what was their actual risk?
Right. What was caries risk to start?
Correct.
That's the first thing that went through my head.
Correct.
What was their caries risk to start?
Correct. How can you actually attribute?
Right.
And especially because it was dead even. It was like 89% protection in one group, 87% protection in another group. And so it was relatively statistically significant that both groups performed similarly. So then you're like, well,
and then was their water supply fluoridated?
Can I read the last sentence of this news article that came out in a main consumer US news? So your average person might pick this up and read it. It's also worth noting that this study looked only at dental caries and not how hydroxyapatite affects more severe issues like cavities.
I'm sorry? Come again?
You sounded Canadian for a minute. I'm sorry.
I'm sorry. Come again?
Yeah,
Pardon?
That's in print.
Yeah. Well,
okay. So anyway,
it's a start, right?
It's a start. I don't know where this is going to go, and I am sort of just leaving it all out there. But I will say it does appear that there may be a bit of a tough road to hold for fluoride. Fluoride is going to, I think fluoride is up for some major testing that's going to come forward, both from a government perspective, and there's just additional data about toxicity issues and how we manage that. And then is hydroxyapatite sort of positioning itself? Are there investors, researchers, scientists, et cetera, trying to position hydroxyapatite as the new replacement for fluoride? And will it perform as well? Will we as clinicians accept it into our new routine of recommendations? Really curious if anybody else is a lot smarter about these particular topics than I am. But I thought it was an interesting consumer-facing article that we should discuss.
What an interesting topic, but obviously, I think there's a lot of meat left on that bone.
I think so too.
Yeah. A lot of problems with it sounds like the control on that study, but listen, it's a start. We have to. The science evolves, and
absolutely.
We need to keep looking. But I certainly wouldn't put all my eggs in that basket at this point.
Can I tell you one other very cool thing that happened on our group this week? So there was a gentleman in our group that reached out about having some sectional matrix issues. And he was sort of fishing like, what is everybody else using? I'm having some challenges. And a bunch of people responded, and he and I kind of chatted a bit. And I said, and it became disclosed what manufacturer he was working with. And it's one of their newer iterations of their traditional sectional matrix systems. And I said, if it's okay with you, I'm just going to reach out. I have some good contacts over at the company. I'm just going to reach out and see if we can get some information. And it's just so cool to watch our community coming together, somebody putting themselves out there to be vulnerable, to ask the question.
Love
and
it.
Then on the manufacturing side and our, folks that we work with, to say, stop the brakes. Or stop the bus. We're going to go ahead. We're going to put together a webinar in the next week and a half. And it's going to be, it's not going to be a sales webinar. It's going to be, if you have the system or you're considering the system, here's how you use it. And then those of you who are having issues or need to troubleshoot those problems, get on and ask those questions. We're going to try to solve that problem for the community. I was like, that's amazing.
Yeah, that really is.
In 10 days, we're going to put that information out and, source it for everybody who needs to have access to it. I thought that was really cool. And I loved the responsiveness of the manufacturer to say, let's nip this in the bud.
That's why we do what we do.
Yeah.
And that's why our educational partners are our educational
So
partners.
cool.
They are not just sponsors.
No.
Like none of us wanted to do that. And
They're
that's,
as invested in our
I
success
know.
in their own unique way as we are.
Right.
Like, it doesn't behoove them to have products that aren't performing well in the marketplace. So
It-
I thought that
yeah.
was really cool.
That really is. Well, I am great job with the news as always. I am going to bring our guest on because we made him sit an extra 4 minutes that I promised him I wouldn't make him sit. But you know what? He's a pretty good guy. I think he's going to let us
I
get
think he'll
away
be
with
okay
it.
with us. I think he
Yeah.
will.
So everyone, Dink's family, I want to introduce you to Dr. Barett Andreasen. He is an accomplished oral and maxillofacial radiologist. He's a lecturer, and he's the founder of the oral radiology practice, Radiodontics. He did his residency at the UCLA School of Dentistry in interpretation, evaluation of CBCT imaging, panoramic, and other imaging modalities. He's worked with all kinds of specialists and dentists across the country, working on things like craniofacial surgery, orofacial pain, oral pathology, orthodontics, other specialties. And honestly, I believe that this is one of the most important specialty areas in dentistry now, because I really think that CBCT, I've already told you, the most important technology you can invest in your practice as a first investment. Hopefully he'll agree with me. But I think that of course there are always concerns about liability, which we'll talk about. But we thank you, Dr. Andreasen, for kind of having the vision to see, wow, there's a lot of people who may need help with interpretation and understanding of what we're doing with all of this incredible information that we're capturing. It's like we went from a PA and a 2D panoramic to a three-dimensional image of everything from, Nasion down to C3. So first of all, welcome. Thank you for being on the show. And maybe tell us a little bit about what gave you the spark to go down this road in dentistry.
Yeah, well, thank you first off for having me on tonight. I'm really excited to talk about CBCT and radiology. I know a lot of people are interested in this subject, but I also know that there's a lot of questions, maybe some hesitations to get into it just because, it's still a relatively newer technology. But as far as what got me into radiology, growing up, I didn't want to be a firefighter. I didn't want to be an astronaut. I always wanted to be an oral radiologist.
What?
No, I'm
What?
just kidding. No, I'm totally kidding.
I think we're
No,
going to have to fact check that
Yeah,
one.
yeah.
Can we get a researchers on that one?
No.
BS meter. Boo, woo.
Yeah, off the charts. No, so going into dental school, absolutely had no idea oral radiology was even a thing. Not on my radar whatsoever. When I first got into dental school, I was thinking about doing orthodontics, but then November of our first year, we had our first kid, and that kind of started putting things into perspective. Stay at school for longer hours to study versus be at home with our newborn and my wife to support her. And so I initially took myself off of that route to specializing. And then getting into the end of second year, third year, I ended up having a conversation with one of my classmates, and just kind of like as a random comment, he mentioned oral radiology and careers surrounding that, and that kind of just like stuck in my head for a couple of weeks after that conversation. And I was like, oral radiology, like I've never heard of anyone doing it. I've never heard of that specialty at all. Like, what does it entail? So I was at Texas A&M College of Dentistry, so formerly known as Baylor, out in Dallas, Texas. And there was actually a radiology program there at the school. And so I had an opportunity to go in and meet with the residents, talk about their prospective careers, what that got them into oral radiology. And, it really just clicked. You know how some things in life, it just like everything kind of
Hmm.
falls into place and you're in the right spot at the right time, and the right people, they push you in the right direction, doors just start opening. That's exactly what it was with myself in oral radiology. And so really just one thing led to another. Next thing I knew, I was applying for oral radiology residency, got accepted to UCLA, and that's just kind of been that. It's been a fantastic career so far for me. I absolutely love what I do. And there's not a lot of oral radiologists running out around town. I think there's like somewhere in the 2, 3, maybe 400 oral radiologists in the whole entire United States.
I
So
didn't know
it's
there were
really,
that many, to be
I
honest with
That
you.
is, it
yeah,
seems
Yeah.
like not,
Yeah.
yeah, I was surprised.
yeah. So we have a pretty tight knit group. So everyone knows each other. Very friendly, small, close knit group. The annual sessions for oral radiologists it's always a fun time because you always see old friends, meet new people that have just joined into the
I would have thought you could have had that at
specialty.
someone's house, honestly. Like,
Probably a couple years ago, yeah, we
yeah.
probably could have managed that. Yeah.
For those who are listening, can you discern for us the difference between maybe what we might expect or see from an oral maxillofacial radiologist versus just a traditional radiologist, or maybe more of an MD track, if you will? Like, how do you
Yeah.
guys look at a CBCT differently?
Great
Yeah.
question.
So I'm a dentist, right? So I
Mhm.
know all things teeth. A medical radiologist, an MD radiologist, they don't speak teeth,
Mhm.
right? So as part of our oral radiology residency at UCLA, we were at the Ronald Reagan Hospital, and we did rotations through the head and neck department. So they're medical radiologists specializing in head and neck. And we would sit down with them and go through cases. They're looking at tumors in the brain, cancer patients, but they would get to the teeth and they're sitting there pulling up charts on Google to be able to like figure out what tooth number they're talking about. And they're asking us about tooth anatomy. How do you describe this? Well, that's a periapical radiolucency, right?
Right.
It's infection. And I remember talking with one of the residents, and they were like, how would you describe this bone loss? And I'm like, well, it's furcational bone loss. And they thought that was hilarious because they never had heard of the word furcational before. And
Yeah.
it's like, well, you have bifurcations and everything. So it's just a totally different language. And so you might have a medical radiologist who's an expert at the head and neck, but being able to translate those findings into something that we understand as dentists, there's a huge discrepancy. And so where I know what a dentist is looking for, whether it's a missed canal, a fractured tooth, or any normal findings that a dentist is immediately going to be looking for, MD radiologist really doesn't have that same understanding.
Yeah. But I think there's also another understanding of, and again, I get in trouble all the time because I love to talk about function and the TMJ and the airway, how all that relates. But I also think that there's a big disconnect, even with regard to the condyles and understanding the structures of the TMJ and the function of how
Oh, sure.
that joint
Mhm.
works and how it relates to the occlusion. There's just, I mean, nothing against the MDs. They could never be exposed to that with the amount of
No.
time that they have in school. And so there's a whole other side that really needs to be understood. And I've often been taken back, even referring MRIs out, and having MD
Totally. Yeah.
radiologists that really weren't in tune with the temporomandibular joint going, you know what? Nothing against them, but it's obvious they don't read a lot of these scans and don't work with dentists a lot. No, again, nothing against them, just a
Mhm.
different training track.
Oh yeah, sure. I mean, it's not their focus,
Right.
right? And you have a lot of MD radiologists, again, they're dealing with patients who are dying of cancer or more systemic issues that aren't typically related to the teeth, to occlusion, to
Mhm.
mastication. And so it's just a different focus, and you can't blame them for not knowing all the dental lingo, all the dental findings, because again, that's not their expertise.
Right.
Can I ask one additional
Yes.
question?
No, please.
And then let's get into the technology for
Yeah.
sure. But
Yeah.
and this is actually for my own understanding, because I'm a CBCT user as well, and that's definitely one of the challenges that I've struggled with between an MD reading one of my CBCTs and an oral maxillofacial radiologist. Would you say that an oral maxillofacial radiologist is reading the comprehensive CT? So are they seeing like a weird ganglion thing, or yeah, and I'm totally speaking out of my context because I don't even know what they're looking for, but let's just pretend like some weird thing growing back beyond, again, to your point, all the things I actually give any care about, right? Like the periapical radiolucency or whatever. Are they cross-trained enough to sort of cover most of the legal liability for any of the data that's being captured in that particular CBCT?
Sure. So on a CBCT, the traditional views that you might have. So a large field of view on a CBCT, you're capturing essentially the top of the skull all the way down, maybe a little bit past the hyoid bone. And as an oral radiologist, we're trained to interpret all of that. Now, I will say that our expertise as far as like a medical CT and MRI goes, we're not trained to go through all of those images, all of those image sets. That comes with that higher training from an MD radiologist. But with the CBCT, we're essentially just limited to hard tissues, right? We can't see any contrast between the soft tissues.
Right.
We can't differentiate between musculature, vasculature. It's all just gray at that point. But we can see effects from pathology on the adjacent hard tissues. One of the more interesting cases that I had during residency was a patient was undergoing just normal ortho treatment, and the orthodontist, they took a just routine CBCT, so large field of view capturing the whole skull. And when you were going through and scrolling through the scan, you can see there was this large discrepancy between the left and the right sides. The orbit was a little bit pushed on one side compared to normal on the other side. And so we started investigating a little bit more. You could see that the base of the skull was lower on that side as well. And so we referred the patient out for an MRI, and lo and behold, they had a cyst within the intracranial region. Now, we couldn't see that in detail on a CBCT, but we could see the effects from that. And so while we might not have the same level of detail in our scans that we can evaluate, we're still trained to go through and look for any kind of pathology or other findings that are present anywhere within the craniofacial region.
So I have a couple of questions. One is, so during that residency, that you're like, okay, I've gone down this path now, and now you're in the middle of just being so absorbed in radiology. Was there kind of an aha moment where you said, dentists really need this? Here's what dentists really need. Here's how I can really help most dentists. Was that moment there for you? And then if so, what was that moment? What was the thing that made you say, I can really help dentists with X?
Sure.
Yeah.
So going into residency, it was definitely one of those situations where you don't know what you don't know, right? Where you really think you've covered all the bases in dental school, you have a really good understanding of what's going on in your imaging. But as soon as I got into residency, especially when I really started working with CBCTs, seeing all the additional findings that we were missing on 2D imaging, seeing all the potential pathology that we were missing, that was kind of my big aha moments. And then in addition to that, then at some point in my residency, I started going on Facebook and joining all these Facebook groups where you have, 10, 20,000 dentists all logging in and asking questions, asking advice. And occasionally you would have dentists posting a panoramic and saying like, hey, what's going on here? And you get 20 different opinions and all of
Mhm.
them are different. And at that point, you're sitting here going, okay, we kind of have a problem here, don't we? If we as a collective body of dentists can't figure out what's going on in our very basic imaging, like what else are we missing? Like on a like for an average dentist, like what are we misdiagnosing? What are we missing? And that was one of those moments as well where I was like, I really need to step it up and become more involved as an oral radiologist, go out and help our dental community understand more fully of what they can do with their radiology, with their images, because we as dentists, we're missing stuff. And that's not good for us. That's not good for our patients.
So the follow-up to that question is, what are you seeing most often for interpretation? What are most of the dentists out there sending to you to say, hey, I need help with this? And is there anything that you think that they should be potentially sending more of?
Yeah.
Uh,
So I think we as a dental community do a really good job at being very aware of potential pathology. So I have a lot of dentists who send in things that aren't necessarily pathology, but they just want someone to double check, right? Whether it's things like idiopathic osteosclerosis or inostosis, whatever you want to call it, just a dense radiopaque area of bone within the mandible or maxilla. We get a lot of those. Just, hey, doc, can you double check? I'm pretty sure this is normal, but I just want a second pair of eyes. We also have a lot of people just sitting in for a general overview as well. We have people, and I know we'll talk about liability in a second, but we have offices who they don't want the responsibility of reviewing their own scans, or they don't have the time to review their own scans, and so they'll send scans to my practice, Radiodontics, and we'll take on that liability for them. We'll review through the whole entire scan and just make sure that they're covered on all bases.
Do you make recommendations as well? Like, this is what we see, and it's a differential. So a biopsy is indicated, surgery is indicated, follow up, additional radiography in a year. Like, are you providing that type of feedback? Because personally, that's definitely an area of deficiency as well. Like, I get that it
Mhm.
is this thing, but because it's not an area of expertise for me, I'm a little bit befuddled at where I go from here.
Yeah, exactly. So we try and stray away from uh, recommending treatment as far as like, oh, you should extract this tooth and place an implant here, because
For sure. Yeah,
that
yeah, yeah.
that
mm,
has so many clinical implications and everything
right.
that I, as a radiologist, can't get into. But as far as pathology, sure, we definitely make recommendations. So, say you have a area of cementoosseous dysplasia, a relatively more common benign lesion. It has a somewhat odd appearance. You have like a mixed density lesion in the anterior mandible next to the root apices of the anterior teeth. It's very benign, very self-limiting, and so what I'll end up saying is, this is an area of cementoosseous dysplasia. It's technically pathology, but it doesn't need any kind of intervention. So we
Right.
don't need any treatment. But what I would recommend is some kind of radiographic follow up. So
Right.
maybe in a year, we take a look again. There might be some minor changes, which are okay because this lesion tends to mature as the patient matures as well. And so we do make those recommendations. If it needs a biopsy, 100% we're going to recommend a biopsy, because the last thing we want to say is like, oh yeah, that's a malignancy, and then the patient doesn't go to get a biopsy done.
Right.
That's kind of the worst case scenario. So we definitely do give those kinds of recommendations, and we're just here to help, right? We're trying to do the right thing for you as well as the patient, and so making those kinds of recommendations as far as biopsy, follow up, those kinds of things, 100%.
So, in addition to that, the question that I have is, how do you think, beyond identifying pathology, in your opinion, how do you think that CBCT technology benefits a new user to the highest degree? Like, what is it that new users see about it? I mean, there's this fear when people want to get into this technology. And again, we'll talk about the liability in just a minute. I want to get to this topic because that's huge.
Mhm.
But the benefits, I've used this technology for over 15 years now. It is the most important thing in my practice. And everyone's heard me say this 10,000 times. But what, as an oral and maxillofacial radiologist, where do you see the greatest benefit to a new user of CBCT technology?
So CBCT, it's one of the few technologies that we have in dentistry that really affects the entirety of your practice. So I know a lot of people may look at CBCT as a technology and think, okay, if I'm doing implants, I need a CBCT. But really, CBCT has become so much more than just implants. So if you're doing any kind of implants, if you're doing endo, perio, any kind of surgical planning, ortho, airway, TMD, every aspect of dentistry can be augmented by CBCT in one way or another. And even if you're just doing bread and butter dentistry, crowns and fillings, you really need to get a CBCT in your office. And the reason why I say that is because, like you guys were talking about earlier, it's all diagnostics. So you have a patient coming in who has decay underneath, say, a crown of tooth number 15. So your treatment plan to redo tooth number 15, take off the crown, put a new one on. Patient comes back a week later and they're saying that they now have pain on this tooth that never caused them problems before. So was that problem there prior to you touching the crown, or did you cause that pain? Well, a CBCT, if you take a CBCT prior to doing any kind of treatment, you can make sure that you're ruling out any kind of very subtle infections that might be present. There's a stat that the American Academy of Endodontists have on their website that talks about 40% of lesions, or 40% more lesions, can be seen on CBCT than on your traditional 2D PAs. So 40%, that's quite a big number, right?
Yeah,
Yeah, for sure.
So you're talking about a significant amount of more endodontic lesions that you're seeing on your CBCT scans than you are on your PAs, on your panoramics, right? And that alone translates into a higher number of procedures, right? You're getting in to do those procedures earlier. You're able to take away those patients out of pain that, like you guys again were talking about, may have been seen by 3 or 4 dentists prior and they couldn't figure out what was going on. And so just the diagnostics alone, that's a huge aspect that really goes hand in hand with CBCT, especially for new users who are just getting into CBCT technology.
If you're looking at purchasing this, like new users, and I sort of fell victim when I bought my first one, that you had to be in some elite ecosystem so that everything talked to one another and that way everything would work together. And I since have changed my opinion on that. Well, that's a whole nother conversation. But
Yeah.
so now actually looking outside of that particular ecosystem box, and I'm thinking about purchasing another one. What are some of the features and benefits that I might look at that would differ? Because they all clout lots of amazing things about their different technologies. So as the average consumer who knows like 5% of the information about a CBCT, how do I discern what is a benefit or a feature that actually means anything to me? Like, I know they think
Yeah.
it's great, but what does it really mean to me as the end user for my patients and for the care I can provide?
Yeah. So the first thing that I'm always looking at on CBCT machines and scans is just image quality, right? You're getting this machine for diagnostic purposes. And if you don't have a very clear image, you're going to be missing stuff. And, that's the whole reason why you got the machine in the first place, is so that you don't miss stuff. And so image quality is always going to be huge. That's one of the primary reasons why I like working with Prexion, is that they have very, very good image quality. And it's not just the scans that the sales reps send me, right? It's The scans that I'm seeing from everyday practices who are taking scans on everyday patients, it's just a consistent good image quality throughout. And that's really the most important thing. The nice thing about CBCT machines and the software that they come with nowadays is they're very friendly as far as working with other software for the most part. So you can export the scan out of your CBCT software, throw it into other software, either to plan out implants or plan surgical guides, do whatever you need to, and they're generally very friendly nowadays.
Mhm.
And then other things, you're always looking for ease of use, right? If it's a more complicated system, it's going to be harder to train your staff on. It's going to be harder to make that switch into the CBCTs if it's just very complicated. So having a very straightforward system that your whole entire staff is going to be able to use is very helpful as well.
I was victim of the idea that I wanted something very small scope, so I wasn't liable for all the extra information. If GPs in particular, because that's what Jeff and I happen to be, are looking at purchasing a CBCT, should that be an area of concern? Like, do we try to get the smallest field of view possible? Because I know what you're going to say because you want to keep it going. So you've got functional dentists that are looking at an airway, and then you've got me who's taking periapical lesions, basically looking for PAs in a CBCT.
I'm a heart valve specialist. I only take images of the valves of the heart. The rest
That's
of the
all
heart
I worry
doesn't
about.
really matter.
I only
the rest
take
of the heart
images
doesn't even matter.
I actually only take images of the RBCs. I don't even give a shit about the valves. Like, I don't even care how they're working. I just want to know what's pumping through it. That's it. I want to be so minor focused. Well, I bought into the idea of we said we were going to talk about it, and by gosh, we're going to do it. I was bought into the liability piece of this, that I would take images of things I knew nothing about, couldn't solve or fix, but would be liable for the information that was captured. And then someday that patient was going to be diagnosed with thyroid cancer or some other crazy condition. And it will come back to my one CBCT that was taken back, 30 odd years ago, that would have seen it at its infancy and could have saved the patient's life. I bought into the whole thing. So number one, let's talk about the buy-in. Let's dispel or prove the theory if that's really true. And two, then whether or not that's true, how do we hone in on the actual scope of size of image that would work best for our practice?
Sure. So let me
tackle that. Was that okay? Was that okay?
I'm go ahead, Barrett.
Let's do it.
This is I'm very strongly opinionated on the fact that we are in charge of everything that happens from condyles down to the masticatory system.
Yeah.
And there are some outliers like airway and things like that, but really that's all our scope of practice. And I'm very curious to hear your opinion on liability, because I've served as an expert witness in a lot of cases. We're really only expected to diagnose what we have been trained to diagnose, or what someone within our geographic area with the similar training would be expected to see. But it shouldn't stop us from taking images, even in areas that we may not be an expert, but that contribute to the conditions that we already treat. So I'm curious your opinion there.
All right, so let's back up a second and let's talk about what our current liability is if we're a doctor practicing without a CBCT. So you take a PA, you're responsible for everything on the PA, right? No questions about it. Okay, let's move on just a little bit forward. So a panoramic, what are we responsible for there? Are we responsible for the jaws? Sure. TMJs? Sure. What about the sinuses?
Yeah.
Nasal cavity? What about if there's pathology that's affecting the orbit and you can see that on the pano? Are we still liable for it?
I think
Yeah.
so. Yeah.
Yeah. I don't think there's any question that anything that you see on a panoramic that you're still liable for. Now, I'm not a lawyer, oral radiologist for those who are just chiming in, right? Uh, there's a number of statements that have been made by some of the governing bodies in dentistry. And let's just review them really quick. So the oh my goodness, ADA has said something along a line of you are responsible as the doctor for reviewing the entirety of your CBCT scan, regardless of why it's been taken in the first place. AAOMR, American Academy of Oral and Maxillofacial Radiologist. Same thing. Regardless of the original intent, you're responsible for the entire image set. AAE, same exact thing. You're responsible for anything that's captured, the same exact reasoning, the same exact liability as for your PAs, as for your panoramics. So the three governing bodies, they've all said the same thing. We're liable for everything that's within our scans. Now, I know a lot of people don't like hearing that because immediately those warning bells start going off, right? Because they don't want to increase their liability with getting a CBCT, but that's just the way that it is, right? I don't think we could get up on the stand as an expert witness and argue these statements. I'm back. They made it very clear that we're liable for everything that we're taking. Now, for the average dentist, what does that liability look like, right? If we're moving from panoramics to CBCTs, are we now all of a sudden way more liable for everything that's ever being taken on our CBCTs? Well, the nice thing with CBCTs is, unlike a panoramic, you can really adjust where your field of view is, right? So if I just want to capture the mandible and maxilla, that's all I'm capturing. And now I haven't increased my liability at all compared to taking a normal panoramic, right? I can limit my scope, my field of view, just to this area, and it's not greater than what we see on a panoramic. And in fact, it's much easier to find pathology on a CBCT than it is on a panoramic. So for those of you who are just limiting yourself to that area, to the dentition and the alveolar bone, you're probably safer taking a CBCT than you are taking your panoramics at this point. Now, as we get further back into our TMJs, into our spine, airway, base of the skull, now you are introducing a little bit more liability because you are capturing more structures. And yes, you are taking more liability on, but there's ways to mitigate that liability as well. So for instance, you can work with an oral radiologist like myself. So for my company, Radiodontics, I have doctors from all across the country sending me in cases. And as soon as they send me that case and I open it up and start working on that report, I take on that full liability to ensure that there's no pathology present. So there was a case recently, I don't remember where it was exactly, but it was discussing a legal case where a dentist took a very large field of view scan on a patient and they sent it to an oral radiologist. And the oral radiologist, they went through the scan and they ended up missing something on the scan. It was in the base of the skull. I think it was metastatic cancer or something like that, but they missed it. And a year or so later, the patient went into their physician. The lesion was found on a subsequent CT scan that was done. And so, of course, the dentist, the original dentist, gets sued. Oral radiologist also gets sued. With these legal cases, everyone who's involved in the case, in whatever capacity, everyone's brought in. But it was found that the dentist was not liable. The original dentist wasn't liable because they had sent in that scan to an expert in the field, and the radiologist was ways to reduce that liability. You can also go in and, take plenty of CE courses. You can go through and read through the textbooks. There's plenty of really good literature, really good examples out there for diagnosing lesions, understanding what you're looking at. And then if you ever do find something, send it off to an oral radiologist, send it off to a oral surgeon, send the patient to their physician. There's ways to get around this liability issue that people might be fully familiar with.
So I think that first of all, that is terrific advice. I mean, we get overreads on I take all large field of view scans and every single new patient. And my philosophy has been, and this is not legal advice, my philosophy personally is that there is a lot more liability to the things that we miss. And as an expert witness that testifies in a lot of cases on behalf of dentists, there is a lot more litigation having to do with what was missed dentally because they didn't get an image of the joints. They didn't get an image of the airway. Because they didn't open their field of view to the other things out there. So I was joking about the heart valve specialist, but if you miss the tumor at the top of the heart because you're so focused on the valves, then what good does the technology do? And I'm not saying that we all have to be an expert in every one of these areas, but when people come to us, particularly when it's a comprehensive problem, I feel like we have an obligation and we have the technology that can really uncover a lot of these problems that we didn't see before and that a lot of dentists got sued over. And we have this at our fingertips. So the number of cases that I see personally where dentists are sued for something that was not diagnosed on a scan in a field of view is almost never for me personally, versus everything that was missed because they didn't image, right? That's where I see way more litigation. And the fact that we have people like you who are there to, for the areas that we are not confident in, to say, okay, I've done an overread on this area. Here's what you need to be concerned about. Here's what you don't. And again, they don't have to be an expert in that area. They can then refer to somebody who is a TMJ specialist, who is an airway specialist, etc. So I've always felt like there's more liability in what we don't diagnose than what we actually image and miss.
For sure.
Yeah.
Like I wish that I could just bring up 1,000 cases just here right now, because the number of cases where there's osteomyelitis that's present that isn't really evident clinically, you can't see anything on your 2D images, but it's clear as day on a CBCT.
Right.
There's cases like that running around, and you miss that as a doctor. Patient ends up in the emergency room. They go under months of IV antibiotics, multiple surgeries. That kind of stuff could be easily avoided with a simple CBCT scan, right? Pathology. I have a number of cases where there's malignancy within the mandible, maxilla, sinus. Can't see a thing on your panoramic. Again, clear as day on a CBCT. So, getting into this world of 3D, realistically, you're more likely to reduce your liability just because you're able to see these things that are going on than missing some very, very rare obscure lesion that you're likely never to run into during your practice.
Right. JB, we have run. Yeah, honestly,
this is such a fun hour.
This is such a fun hour, and
I could keep going. I have so many more questions.
Yeah, and I could talk about this forever too, because this is it's such an important part of what we do diagnostically now, and that's how the conversation started. And I really appreciate that, and I appreciate people like you, Dr. Andreasen, who have kind of jumped into this field, maybe not even knowing what it truly was, but what you're doing for dentistry is so invaluable. I mean, it's just
thank you.
Yeah, it's
Can I just say one other thing that
please?
I met with a MD radiologist one time, and one of the things that really was impactful that he stated was how amazing the image quality was coming out of your average run-of-the-mill general dentist office. When you think about, especially from an MD radiologist who's basically getting most of their reads out of large hospitals or like major medical or radiology centers. And then you've got, even in rural communities, these phenomenal dentists taking high quality images in their own offices to obtain high quality diagnostics, I think was quite like an aha moment for him to realize how much great imaging is happening on a very local level inside general practice offices all the time.
Oh yeah, they're beautiful images. Like the CT machines that they use at the hospitals really don't have the same resolution or even the nice, beautiful images that we see on your basic CBCT machines nowadays. Medical doesn't have anything on us right now.
Yes, that's all I wanted to hear. Close the program. Shut it down.
Shut it down.
Medical doesn't have anything on us.
Dr. Andreasen, thank you so much for joining us. I hope that you'll be a regular guest with us because I know that there is so much that we have not even talked about tonight, and you're a wealth of untapped knowledge. So we appreciate you being on. And
next time he comes back, we'll just do images. Like we'll go.
Oh yeah,
I would actually.
That would be so fun.
Yeah, I think I really think that our viewers would appreciate that. Is just seeing a bunch of images and then seeing how you look at it versus how they look at it within practice. So we have a great new idea. Dr. Andreasen, thank you so much for being with us.
Of course.
We appreciate you. We appreciate our educational sponsor, Prexion. And JB, why don't you close us out for the evening?
All right, you got it. So first off, I'm going to post the link for the Garrison webinar so that our members, and honestly, anybody in the dental community that wants to learn more about that particular system or troubleshoot their own current challenges will have access to live online support. And we'll just have a good time. I cannot thank our guests tonight and Prexion enough for the educational opportunities that we had and the continual growth in our profession. Thank you, everyone, for tuning in tonight or listening on our podcast or YouTube channel. We're so grateful and thankful for our dedicated members of our community who continue to bring us great ideas, activity, and inspiration on a weekly basis. And with that, have a great night.
Have a good night, everyone. And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.